Good afternoon, everyone. I'll dive straight into the topic. The topic is focusing on myopia. We are all aware that myopia is a global health issue, and it has been the subject of major discussion, and a lot of international research is happening on myopia as to how it is developing and how to control it. As we can see that this high myopia is linked to ocular morbidity like cataract, retinal detachment, myopic maculopathy. Hence, there is a need for a proactive management. How do you evaluate a patient with myopia? Most important is history taking. We have to consider the age first. Younger the patient, more the chances of progression. If the parents are myopic, then the more chances of progression is there. You have to consider the amount of time spent outdoors, the amount of near work that they do, and amount they spent on the gadgets, and presence of or correlation with any other binocular vision disorders. We have to do a good refraction, do good cycloplegic refraction with the ocular accommodation relaxed. We have to assess for accompanying binocular vision anomalies, because these children with binocular vision disorders have been linked with earlier onset, faster progression, and different outcomes with myopia control modalities. Slit lamp examination is done to rule out secondary causes of myopia, any possible syndromic associations, and a good dry eye evaluation also has to be done if we are considering contact lens. Fundus examination is done to rule out posterior segment pathology or any degenerative retinal disorders. A corneal topography can be done in case we are considering contact lenses or the orthokeratology lenses. Axial length measurement is of prime importance because children below 10 years of age, they have a faster growth in the length of the eyeball. As you can see, 7 to 10 years of age, emetropic eyes, they have a growth of around 0.1 to 0.2 millimeter per year, whereas myopic eyes, they have a faster growth around 0.3 millimeter or beyond in a year. Children, once they reach the pre-teen years or the teen years, there's a stabilization in the ocular growth, and you can see that there's a slowing down of the axial length. So this axial length can be used as a single measure to indicate myopia-associated eye disease risk, or it can also be used as a repeated measure to gauge the efficacy of the myopia control management measures that we are going to follow. The other exploratory tests are related to peripheral refraction, associated higher order aberrations, the pupillary size, subfoveal choroidal thickness, and wearable devices to track the visual habits and the environment. So we have to adopt a comprehensive strategy. First, we have to prevent the onset of myopia. The patient who comes with myopia, we want to prevent high myopia. In case the child is high myopic, we want to prevent the complications associated with high myopia. So as a primary prevention, if there is no myopia or children with myopia, as an adjunct treatment, we suggest behavioral modifications. So most important thing is screens down, eyes up. So these high intensity light triggers the release of retinal dopamine, which acts as a ocular growth inhibitor and inhibits myopic development. Other behavioral modifications would be following the elbow rule. That is, the objects has to be kept at the distance of the elbow distance. We have to limit the amount of time used with the gadgets to less than 2 hours and follow the 20-20 rule. So how do we keep the myopia under check in patients with myopia? So we have to aim for slowing down of progression of myopia by at least 50%. Hence, we will also be preventing the long-term complications associated with it. When do we start the myopia control measures? So if the patient has a high risk for progression, younger the age, higher baseline myopia, or the parents are myopic, or if there's a documented myopic progression, we can consider the myopia control measures. So how to choose the treatment modality? You have to consider the baseline refractive error, binocular vision status, and of course you have to consider the availability, affordability of these treatment measures, associated ocular conditions, and patient and the child preference as well. So what are the available strategies at present? We have the optical strategies in the form of spectacles and the contact lenses, and pharmacological therapy in the form of low-dose atropine. Coming to spectacles, our first responsibility when we treat young myopic individuals is to correct their vision. Hence, the logical first choice would be the treatment which corrects both the ametropia as well as providing myopia control. So it would be either the spectacles or the contact lens prescription. The spectacles, it is easy for young children because of the safety and the compliance. The possible strategies are the progressive addition lenses, executive bifocals. These progressive addition lenses, they function well or they are more effective in children with high accommodative lag or esophoria. Executive bifocals and the prismatic bifocals, they have a modest efficacy in myopia control, with these prismatic bifocals working better in patients with low accommodative lag. The recent development of the peripheral defocus lenses, they seem to have a better efficacy in myopia control. It corrects around 60%. It has a control over 60%. So generally when the patient wears a single vision glasses, the central rays gets focused on the fovea, whereas the peripheral rays, there's a small hyperopic defocus. So this peripheral hyperopic defocus, it acts as a stimulus for the ocular growth. So then the reverse is supposed to be beneficial. So these visual signals coming from the peripheral retina are stronger than those coming from the central retina. So they came up with this principle of inducing a myopic defocus to control myopia. So the available lenses in the market at present are the Myosmart lenses, the Stellest lenses, the Zeiss MyoCare lenses. So these newer generation lenses appear to control myopia or reduce the myopia progression by around 50 to 60%, and also have an efficacy on controlling the axial length prolongation as well. The other optical strategy is the use of contact lenses. So children with higher refractive error or children who are active into sports or presence of accommodative lag or poor responders to other modalities can choose contact lenses. So same concept of myopic defocus is what is seen in these contact lenses. So there's a central clear zone for visualization and a peripheral zone, defocus zone, which induces myopic defocus and helps in myopia control. The pros is it's a one-size-fits-all approach. The cons is there is always a risk of infection, and also it is limited to correct patients with associated astigmatism. The efficacy is around 60% for contact lenses as well. The other form of contact lenses is the orthokeratology. So the orthokeratology lenses, the patient can wear it overnight, and in the daytime the patient can be spectacle free. So there's a central flattening of the cornea happening in children who wear the ortho-K lenses. That helps them seeing glass free in the daytime. So as you can see, there is once the patients wear the orthokeratology lenses, there's a central flattening and mid-peripheral steepening. This is not epithelial thinning, but there's a redistribution of the intrastromal fluid happening when the patient wears an orthokeratology lenses. So this is how the patient is able to see glass-free in the daytime. So the pros is that the patient can be correction-free in the daytime, but there is always going to be the risk of infection in patients who are using these ortho-K lenses, and also a rebound on discontinuation. The pharmacological treatment, as most of us are aware, and we are all practicing the same as well, is the low-dose atropine. How does it have effect? How does it control the myopia? It acts on the muscarinic receptors in the retina and the scleral level and the choroidal level. In retinal level, it influences the release of dopamine from the amacrine cells, which modulates the ocular growth. In the scleral level, there is a scleral remodeling happening. As we can see, there is a dose-related efficacy in atropine. So higher the dosage, more the efficacy, but hand in hand the side effects also increase. So to balance both the risks and the benefits, 0.05% of the atropine seems to be very efficacious. The pros of using a low-dose atropine is that there's a strong clinical trial data and it is easily available and also economical for the patient. The cons would be there is a possibility of a rebound phenomena on sudden discontinuation of a low-dose atropine. So when do we stop the atropine treatment? We can suggest the child to use the atropine till he reaches his teenage age, or if there's an axial length stabilization of around 0.1 millimeter change in a year. So how do we gauge success of the treatment that we are adopting? There should be a positive and a meaningful impact on both the refraction and the axial length. There should be no rebound on cessation, and there should be minimal negative impact. So of all the available treatment modalities in the optical strategies, multifocal contact lenses and the defocus incorporated multiple segments seem to be efficacious of all the other prevalent strategies. And in the pharmacological group, we see the 0.05% of atropine being the most efficacious of all the other available drugs. So if you need the first choice, that would be the 0.05% of atropine, followed by multifocal lenses, orthokeratology lenses, and the DIMS lenses. The other options would come as a secondary. Thank you for your attention. Virendra sir, do you have anything to add, sir, please?
It was wonderful talk, Dr. Vaishali. You covered all aspects of myopia treatment. And what is also important, as you highlighted, that we have to identify which patients are at risk of myopia progression, and after documenting that they are having axial myopia. All these treatments will work when there is axial length elongation. So axial myopia, which is progressing at a rate of more than 0.5 diopter per year, are at would benefit by this kind of treatment. Just maybe I think this is something I would like to add, that everybody should know it, because all of us can contribute to taking care of children's health. And may I just ask, how many of you are prescribing low dose atropine? So everybody is prescribing. How many of you have shifted to 0.05% atropine as the first line? So as Dr. Vaishali pointed out, the efficacy is more, but at the still majority of the recommendations tell that 0.01% is good enough to start, and you can increase it to 0.05%. And lastly, I will just like to add, in interest of time, is that it's a multimodal approach. You look at the patient's risk factors, start with one, and you can always go on to add another. Thank you.
Dr. Prajna sir, please come and give memento to your student, Dr. Vaishali.